All right, gang, in our last section, what we're going to really focus on is case studies. We are busy clinicians. Every one of us sees a bunch of patients all week long, every week, and does our progress notes dutifully and calls referring physicians, hopefully. I think we just talked about the complexity, if you will, of the data. Marwan did a great job of saying, well, I'm going to play the chess game differently depending on what patient I'm seeing. So what I want to sort of shape for our audience is, what kind of patient would you use one medicine or another? We're going to teach chess now, right?
Okay.
Checkers is easy.
Let's go.
But now we're going to teach chess. You know how the players move on the board, but when do you move what player? When do you take one? When do you back off? This sort of thing. And let's start with the first medicine we were featuring, and that's cetuximab. All right, so first for this discussion, let's just assume you've done the extended mutation analysis, and you're a wild type, fastball down the middle wild type with a metastatic colon. What are some of the characteristics, and Johanna, I'll start with you. What are some of the characteristics of a patient that you might use first-line cetuximab therapy?
Someone who doesn't mind having a rash for about 10 months
So
at a time.
toxicity.
Toxicity is the biggest issue for me. And I think that if I were to choose a chemotherapy backbone, and we've talked a little bit about this, especially in the first-line therapy, given the new EPOCH data, albeit in resectable patients, but showing a detriment to using cetuximab plus oxaliplatin-based therapy in the first line for those resectable patients, I would probably use it a la Crystal and actually use it with a FOLFIRI-based regimen.
What about resectable versus not resectable, symptomatic versus not symptomatic? Does that change your decision-making in a frontline setting?
In terms of biologic, not as much, because I find that with any chemotherapy backbone and the biologic backbone, you get good response rates there. There's some discussion about using something like FOLFOXIRI to see if you get a better response rate. Interestingly enough, the TRIBE study, which we saw at last year's ASCO, looked at bevacizumab plus FOLFOXIRI versus bevacizumab plus FOLFIRI and found that though you improved response rate, they actually had a secondary endpoint of seeing if more patients went to resection. In fact, they did not see that. Nobody can quite explain why that is, and it's small patient numbers, but I tend to, if I do need a big response rate, I might use FOLFOXIRI followed by a quick maintenance regimen after about 4 to 6 months.
But I'm hearing a lot of thought leader folks say, if you've got the KRAS or the RAS pan wild type, that you really should be using EGFR. What's your position on that?
I mean, as I said earlier, I'm discussing this with my patients. I am using it in the frontline therapy, not as much as for downstaging, because I believe you can downstage with FOLFOXIRI. I agree with Joanna that we didn't have more resection in the TRIBE, but we also have the Olivia clinical trial, which was for patients who are unresectable, where a triplet chemotherapy was better than a doublet, and by far as RO resections. And if I have a borderline resectable, unresectable patients that I want to convert, I think I want to use either anti-EGFR therapy plus my chemo, or I want to use FOLFOXIRI, probably more towards FOLFOXIRI. We also have to remember, not a great study, but there is a JCO manuscript that has looked at combination chemotherapy plus cetuximab versus chemotherapy in unresectable liver metastases that has shown increased resectability as well. So it depends on your goal. If it's unresectable but potentially resectable, I'm going to go aggressive. Good performance status, tolerates FOLFOXIRI. Kind of not that great, I may tone it down to a FOLFIRI plus cetuximab. Or.
So I'm not hearing either or, that if the gene expression is all wild type, this is what I'm doing. It's still a decision, resectable or not resectable, toxicity based. I'm assuming we'd all say if they had some recent stroke or some contraindication to Bev, we would incorporate one of these in first line. But let's go to second line. All right, so let's say we're typical Americans and we have given first line FOLFOX or capecitabine and Bev, okay? Nice, an initial therapy. Again, wild type RAS. Give me a patient where you would do Bev beyond progression and give me a patient where you do cetuximab beyond progression.
Yeah, I think that's a good challenging question, because I think you have two options, and when you look at the outcome data in EPIC or in TML, they are very comparable. I don't think you have a clear winner. I think still that when you have a symptomatic patient, a lot of tumor burden, I probably would prefer an EGF receptor. I still believe that the potential tumor shrinkage or the death made me a difference. So I think I drive more by clinical symptoms rather than the biology behind it and thinking, what should I do with angiogenesis? But BEV is also a good option for this patient population if they are indolent and have not really symptomatic disease. But if I want kind of quicker tumor shrinkage for symptomatic reasons or tumor burden, I would use an EGF receptor.
So Alan, is it maybe a quality of response in that first line or timing of response when you might go from a VEGF to an EGF?
I think, as Marwan said, it's an instinct, and it's sort of the art of trying to.
But we're trying to teach these folks what that instinct looks like.
So I think the instinct is looking at the whole picture, what the window of opportunity is to make a difference. I agree with Heinz, Joseph. If you think you've got one bite of the apple, then I'd be more aggressive with combination therapy, probably with an EGFR. One of the places where I think we find that frequently in the community they don't realize what the options are in patients who have a high bilirubin, for example, where they steer clear of anything. And in fact, we'll give Folfox and an EGFR inhibitor, and we've had some dramatic responses in patients who were told, gee, your bilirubin's 10, we can't do anything for you. So I think there are subsets of patients where we can be aggressive where you wouldn't think we would. Again, it is really an art. My view is, the first question is, what's the goal of therapy, and what toxicity profile are the patients willing to live with, and then we go from there. I also think the multidisciplinary assessment of the patient is hugely important, and that's to establish the goal. Is this
at the beginning?
At the very beginning, and,
yeah.
and subsequently, we see too many patients, in my opinion, who come in for they're down the road a year or two, and you realize they have resectable disease, or they had resectable disease. This is a missed opportunity. And so I think the take-home message to me is, however we treat them, it should be knowing what the goals are. And the other issue that we are very keen on is, when do you change therapy? So there's the RECIST criteria, right? That's for clinical research. That's what we change therapy when the tumor goes from 1.8 to 2.6 centimeters. Is that the right time to change therapy? I think those are the things we need to refine, and that's more the art. Do we do PET scans to follow patients? We don't. I don't think we should, and yet this is common. So many of these issues may be every bit as important or more important than which agents we use.